My name's Catherine Moore, and as you can see from the title, I'm a principal clinical scientist, and I work for Public Health Wales, and I'm based in the Cardiff laboratory. But what's quite important to remember, Public Health Wales actually, as part of a devolved government, we look after the health and well-being of the population, the entire population of Wales. So although my base is in Cardiff, I also have input into the laboratories all around Wales, and certainly in terms of the surveillance of respiratory virus infection and now into respiratory pathogen infection in Wales. I'm just going to discuss some of the principles behind that, and also how we can use surveillance in actual tertiary services, how the information we can provide from the community feeds into that, and to look at emerging infections and how we can perhaps predict what might be coming, and hopefully you'll learn something from that. I want it to be quite informal, so if there's anything that you don't understand, please ask me during the talk. I'm quite happy to stop. Okay, so we first start of all, this is I think quite a real slide, and there's a general perception of clinical importance of various respiratory viruses, and this sort of really pinnacleizes for me that influenza is seen as the top priority in terms of most hospital acquired infections, in terms of respiratory infections. For us, in surveillance terms, we're looking at influenza in terms of genetic changes which might lead to sort of outbreaks in terms of vaccine efficacy failures, and also future pandemics, so pandemic threats. Respiratory syncytial virus actually sits in the middle of that. Now, that's something that we every year predictively will have RSV outbreaks in our hospitals, usually coming in from the community, usually associated with very young children. And it's something which I'll discuss with you later. But underneath all of this, the baseline is actually the other respiratory viruses. And really, there's been some sort of underestimation, really, of what the impact of these viruses has been over the years. But actually, when you look at it, all viruses can cause significant issues in certain vulnerable patient groups. So if you have somebody coming into hospital with one of the other viruses or other pathogens, you still have to treat them as if they're an infection control risk. So the issues that we have in Wales is social deprivation, and this is something that we all have in common, that basically there are pockets of population where you see social deprivation. The sort of blue areas along the bottom here, which I'm highlighting, this is the South Wales valleys, and this is where we have high levels of unemployment and high levels of sort of social deprivation, children living in poverty. We have some of the worst levels of social deprivation in the whole of the UK. But of course this expands across the whole of Wales, and certainly pockets in England. If you look at this graph along here, this is where Wales sits, and this is some areas of London here. So you can see that social deprivation is a real issue. But what goes hand in hand with that is going to be the health of the nation, because social deprivation and poor health go together. And so when you're looking at respiratory virus surveillance, you have to look at the population and look at what their significant risk factors are for those viruses or those pathogens that they're going to pick up. What's the likely burden going to be to that population? Are they going to present more severely in the hospitals? And what are the likely outcomes? What should we be doing within the community that we can do that we can support these people? And on top of that, we have the emerging threats. So in the last 10 years, we've had lots and lots of respiratory pathogens appearing in various parts of the world. And this is beyond influenza. So if we look at coronaviruses, which is the top picture here, these are the coronaviruses. Years ago, sort of 1960s, we knew that coronaviruses existed, so 229E and OC43 were viruses detected early on, always associated with common colds, never looked for routinely in hospital laboratories, and they're still very rarely looked for. And then sort of mid-90s, we had the emergence of the SARS-CoV virus over in the Asia. This is a zoonotic infection, probably started in bats, but intermediate target with the palm civet, so associated with eating tropical meat. As a result of that, people started looking at coronaviruses in a little more detail, and this is part of the surveillance. They go back and have a look at what they knew people had virus infections, have a look at those virus infections, do some whole genome sequencing on it or random sequencing, and they discovered new viruses, so the human coronavirus NL63 and human coronavirus HKU1 were discovered as a direct result of the SARS-CoV outbreak. And these viruses have been associated with severe infections, and particularly in children. But again, not routinely screened for. But of course, in the last few years, we've had MERS-CoV emerge in the Middle East. And this again is another zoonotic infection, probably primary host in bats, but we have a lot of indication that perhaps camels are the intermediate host in this. And this is something that we're constantly monitoring, and we have enhanced surveillance as a result of these emerging infections. And at the bottom there, this one here, these are the enteroviruses. Non-respiratory types include polioviruses, so something that we already have a vaccine for. It's a constant battle to ensure that we're actually covering polio to eradicate it globally. Enterovirus 71 causes massive outbreaks in Asia. There's now a vaccine available for that, so that's going into trials. Coxsackie viruses, significant problems in neonates, and also the echoviruses, which we see outbreaks of those associated with aseptic meningitis. So we kind of know that the enteroviruses are an important group of pathogens. They're also very closely related to the rhinoviruses. So if you're running rhinoviruses, or you know that rhinovirus assays are being run in your local laboratory, it's highly likely that you'll also be detecting enteroviruses as part of that screen, because they're so closely related. It's very hard to separate them genomically. And in the US last year, you may know that there was an emergence of a virus called enterovirus D68, and it was associated with severe respiratory infection, but associated with that was a flaccid paralysis, very similar to poliomyelitis. And what we know is that enterovirus 68 was actually discovered in the 1960s, so it was a virus that we all knew about. But what we had now was a new sort of symptomatic course of infection associated with it, and we were put on alert. And so as part of our surveillance work, and which I will talk to you a little bit about now, we can go back into our surveillance samples and actually see what level of enterovirus 68 we actually had in Europe. And it actually showed that we had it circulating all the time in our respiratory samples. And indeed, from that surveillance, we found 3 cases of flaccid paralysis in Europe associated with this infection. And so it just shows that, you know, emerging infections are something that we should all be aware of, and it's not all influenza. What comes with that, of course, is increased public anxiety. So this is some news stories here from America, from the enterovirus cases. There's lots and lots of information put out there on how you can diagnose enterovirus clinically in your cases, which actually becomes very difficult. And also here, we've got pathogens know no boundaries. So this is travel. So this is the epicenter of the MERS-CoV outbreak, and you can see that flights have taken MERS-CoV to other countries. So we're already on enhanced surveillance almost for MERS-CoV arriving in the UK. And of course, then you have social media. And when every time that there's an issue with a pathogen or a newly emerged pathogen, you can either have positive media or you can have negative media associated with places like Tumblr or Facebook or certainly Twitter. And it's actually things like that we should be monitoring as well, because new emerging infections could also appear. People starting to complain of having a respiratory infection, clusters of them on Facebook. And we can actually use that to actually pick out, are we seeing unusual clusters in this particular area? And of course, clinically, most of these infections actually present the same. And this is just a screenshot that I've taken from the US site. And actually, so what are the symptoms? So they've put influenza here. Ebola is actually sitting in the middle here, and the enterovirus D68. And actually, if you look down the list of symptoms, they're all really, really similar. And so unless you have a virological or pathological or microbiological confirmation of that infection, I mean, obviously, Ebola, you would have a very good, strong travel history, I would hope, associated with diagnosing an Ebola case. But certainly for flu and enterovirus D68, if it's already in the population, it's actually very difficult to diagnose clinically. So I have a working hypothesis which I use in Wales, and basically what I do is I continuously monitor the baseline circulation of respiratory pathogens in the community and the hospital. And so what I want to know is, what's the normal pattern of circulation, and can we understand disease better by knowing that circulation? What are these people presenting with? What time of year are they presenting with? Are they certain age groups? Are they certain vulnerable groups? And as I say, Wales has got a high level of social deprivation. So are they particular groups within the population that are coming in with severe forms of viruses that we would normally consider to be innocuous in normal healthy people? And by doing this, you can start to see unusual events that can be detected, and then we can follow those up. So these might be clusters, they could be outbreaks, or they could be very severe disease in a population that you wouldn't normally expect to see severe disease in, associated with that particular pathogen. And coupled with that, we have something called active and passive disease surveillance. So you have the epidemiological type, which shows trends over time. So this can be spatial and temporal. And then we have the microbiological. So this is laboratory confirmed. And what we try to do is bring those together. We have analysts to help us do that. And then we can start to look at these patterns in association with time of year and seasonality. But there have been huge growth in factors that have improved microbiological surveillance. So I've put microbiological. Normally I would be saying virological, but we're now beginning to sort of expand our screening into the bacteria as well. Because we have a constant need to monitor the influenza circulation. This happens all the time. It's like almost going on in the background. We constantly look to see where flu is happening in the world. And this is part of our priority, essentially, is to know what's happening with it. And also the introduction of molecular diagnostics. They're rapid, they're sensitive, and they're specific. And more importantly, when we're talking about emerging infections, you can make a sample safe prior to doing the manipulation to do the detection. So, for example, I was in Sierra Leone in December. I was able to take a sample from an Ebola case, make it safe, and then perform a molecular diagnostics, basically almost in an open laboratory after that sample's made safe. So molecular diagnostics really opened the field to allow us to begin to look at these more dangerous pathogens, unusual pathogens, in your general microbiology laboratories, with extra added safety put in. So we have various respiratory infection data sources, and this is in Wales, but actually if you can look at the whole of the UK, we have very similar sources. So the first things that most people present with is an acute respiratory illness. So most of us will sort of recognise that. So you have a cough, a little bit of a fever, you don't feel so great. And following that, you have the influenza-like illnesses. And this is more of a specific description. So this is where you have a high fever, sudden onset myalgia, pain, the normal things you would associate with influenza. There's always a thing that you've had flu because you feel absolutely rubbish. These are usually home or self-medicated. We encourage people not to go to your GP if you are healthy. You may ring NHS Direct if you're particularly worried if your child has a temperature, but this is pretty much as close to care that you will actually get to, or we would hope that you would get to. So generally this is underreported. So this is your baseline. We don't actually see a lot of this going on. Of course, if you have an underlying condition or a chronic condition, you may get an exacerbation as part of that. Then you may have contact with your primary care physician. And this is where we're interested in part of our surveillance, is who's going to the GP and what are they going to the GP with. And this is what we call our community surveillance networks. Then you have the severe acute infections. These are the guys that will end up in your hospitals. These are the guys that would normally expect to turn up in accident and emergency, potentially go on to ITU, go on to the wards, and these are the people that would be diagnosed within the hospital. And so you have contact then with tertiary care. And as you can see, this really overlaps sometimes with the influenza-like illness. Some people just cannot just wait for a GP. They will take themselves to accident and emergency. And this is what we call hospital surveillance. So basically, this is we just pick up the data from the routine stuff which is coming through the hospital laboratories. And then we have the deaths. So people may come into hospital and they may die as a result of their infection. And we also have sudden deaths in the community. Again, these are generally underreported. We don't do many autopsies anymore. We're not, when people die, if it's a known underlying cause, that generally goes with it. So you just don't really know whether respiratory viruses or respiratory pathogens have actually been associated with it. So virological surveillance then sits underneath the community and the hospital surveillance. This is when we would want people to take a sample so that we can virologically confirm that the GP thinks that it is a flu, or it's something else. And this is where we would come into it. Of course, what we would have then, this is the historical context of Wales over many years. So from 1996 down here, all the way up to April 2015. And this is consultation rates per 100,000 to general practices in Wales. And you can see that really the last time that we had what we would call a good sort of robust influenza season was back in 1999 into 2000, when it got into higher than average. And actually, when you come here, this is the pandemic year here, where we used to have these two sharp spikes. And then we had a robust year here in 2010-11, when we genuinely had a lot of influenza. And this would fit with a pandemic, wave 1, wave 2, wave 3. So that's generally what happened in that year. This is the current season here, sort of fairly low. So we've had the last 4 years pretty low influenza seasons, with maybe just one actually popping over when we would actually call it normal seasonal influenza activity. So since the pandemic, according to our GP surveillance, we haven't had a lot of flu. This is out-of-hours consultation rates, and as you can see, it bumps along, and usually it peaks over the winter seasons. You get consultations. These are people who are ringing the GPs out of hours. And this is this year, so 30% of the cases were associated with influenza-like illness ringing out of hours. But none of this is virologically confirmed. This is just people phoning up. But we can take this data and we can say this is what the patterns are showing in the community. This is phone calls directly to NHS Direct. Now this, remember the last big season that I showed you? So you had wave 1, wave 2, wave 3 of the pandemic. With this green wave here, that's the last good flu outbreak that we had in Wales. And as you can see, you had a huge percentage of calls, over 10% of the calls to NHS Direct in Wales were due to flu. This year, we're grumbling along really quite low. So really, we had very few percentage of calls. So GPs are telling us in the community, there's no flu out there. We all know in this room that that's not correct, because something was going on this year that was not being recorded in the community. So virological surveillance, this is where this really comes in to play. And so we have a number of things. So in Wales, we have 44 primary care sites across Wales. And what we ask them to do is if a patient presents to them with what they think is an influenza-like illness, they take 5 swabs. Our definition of flu, sudden onset, myalgia, sore throat, cough, and rigors. Generally, that's what we would expect them to see. Most of those patients don't go to the GP until 5 days afterwards, when they can actually get out of bed to go to their GP. So more often than not, they're outside of the time that they can have a sample taken, or they're negative, because the virus is already gone. They've already recovered. We've been using molecular assays for this screening now since 2005, so we're one of the longest UK nations to use molecular surveillance. And we expanded our testing in the community beyond influenza since 2007, and added to that, we do it all year round. So the standard influenza season starts at week 40, so approximately the beginning of October, and ends in week 20, so April, May time. How do we detect influenza viruses? Because this is obviously the key to all of this. So there's 3 types of flu. There's flu A, flu B, and influenza C. Hands up anybody who's ever seen an influenza C. Yeah, exactly. Nobody really knows what it does, so we don't routinely look for it. Now, should we be looking for it? Because some of the indications are that flu C does cause problems. We just don't have the capacity yet to detect it. So generally then, we've detected flu A using our screening study. So we have a generic influenza A molecular test, but we can't stop there. For surveillance purposes, we need to know what type of flu we actually have. So it can't be just flu A or flu B. We need to know what type is associated with that. So could it be an H1N1, so that's your pandemic flu? Could it be an H3N2? So when we base those on the hemagglutinin subtypes, we have specific molecular assays to subtype our flu A for us. Now that's important for treatment, because if you're immunocompromised and you have an H1N1 virus, the last thing we want to give you is oseltamivir. We want to give you zanamivir. So that's actually important to do the subtyping as well, because we don't want to drive resistance. At the bottom there, because if you can't subtype, are we looking at something that's just emerged? Are we looking at an H5N1? Are we looking at H7N7? Are we looking at H9? We're looking at the avian flus, the swine flus, which could emerge in the population, particularly with travel history. So if they don't type, we need to get the travel history, find out where they're coming from. Are we looking at a new strain of flu? Flu B is not just flu B. It exists in 2 lineages, Yamagata and Victoria. So those are the flu B lineages. And we usually call those in seasonal influenza. We don't stop there. for surveillance purposes, because we need to know whether the viruses that we're detecting in the community are actually vaccine matched. Right? This is going to be quite difficult for you to see, but hopefully these little spots here represent viruses antigenically matched. In the middle there is a red dot. That's the vaccine for H1N1 swine flu. Now, actually, all of these isolates cluster very closely around it. So that shows to us that all of the viruses that have been isolated are a good match to that vaccine. H1N1 viruses do not drift very quickly. They infect younger people because the older people hopefully will have met the virus or have been immunized, and so they don't have the risk of acquiring infection. They may get a mild infection, later on as their antibodies wane, but that usually boosts. So that's why H1N1 we usually associate with younger people and more severe disease, because they will never have met that virus before unless they've been immunized. H3N2, however, which we'll come on to, is slightly different. It's much more broadly based. Now, this is a virus which drifts on a regular basis. And so every 3 to 4 years, we have to change the vaccine because the virus has drifted away from what's currently in the vaccine at that time. The vaccines that we use in the UK are subunit vaccines, so HA and NA, and we have to change those components each time the virus changes in the population. And that's why the virological surveillance is so important, because we have to keep matching that vaccine. And of course, then, as I said to you, H1N1 viruses are prone to resistance. So what they do is they accumulate a resistance at a site in the genome, and neuraminidase inhibitors no longer work. I mean, in particular, oseltamivir no longer works. So the frontline test you would normally use doesn't work anymore. So we'd have constant surveillance for resistance to the neuraminidase inhibitors as well. Because if the vaccine doesn't work, we want to make sure that the treatment that we can offer also works. So this is this season in Wales, and as you can see, I haven't put the 2010 on here. According to this, the last time that we had any significant flu was in 2012-2013. This is the GP consultation rate. Something is horribly wrong here, isn't it? I mean, it's just that we had lots of flu, but the GPs just didn't see it. But according to us, our flu season started in week 50 and it ended in about week 10. Now, that's important because if we know that flu's circulating, we can give oseltamivir in the community. And according to GP surveillance, we could only give it for maybe 8-9 weeks of the year, right? When you look at the hospital data later, you'll see that that really wasn't valid. This is the virologically confirmed cases. This is the last 3 seasons. So here's that big season I said there. So we had flu B in green and flu A followed that. That's H3N2. Very quiet year here. And then suddenly you have this huge peak here. This is all in the hospital. It's not in the community. So suddenly we were seeing lots and lots of flu coming into the hospital, but not in the community at all. And then we have our little tail here of flu B, which is still ongoing. We're still seeing some flu B in the community. We tested 2 samples from the beginning of the year, so about week 40. We sent it off for antigenic typing, and they came back with an HA genetic cluster of 3C2A. That is very distinct from the current vaccine. So we had drift already happening, and this drift means that the vaccine wasn't matching. And so suddenly we were starting to see cases of flu, outbreaks in nursing homes in particular, older people coming down with influenza despite being immunized. And that is always a concern. So as soon as that happens, you have to put on guard and say, okay, even if you've got an influenza, in fact, if you've suspect they've been vaccinated, they've been immunized, please give oseltamivir until you get the laboratory results. And a small number, if you've lineage typed to flu B, you've been Yamagata typed. And again, that's drifted. So the vaccine's not great for that either. So some of the surveillance data gives very bad results. So our intermediate flu vaccine reports, we give half-season estimates of what the vaccine efficacy does. So all of the 5 nations in the UK and Southern Ireland provide data for this. And we gave a positivity of about 3.4% effectiveness of the vaccine this year in mid-season. And that caused a whole heap of hell come down on us. It was like, why have you published this? The vaccine isn't working. But it was reality, because even though the GPs weren't seeing it, it was in the hospitals. And because we know that the vaccine isn't as working so well, we need to give something else. And so oseltamivir had to be pushed. And actually, if you look globally, it was the same picture all over the world. So this is North America here, and you can see in the brown bars, this is H3N2 viruses. This is Europe here. So it wasn't just us. When we fed into the global surveillance networks, we were seeing the same pattern across the whole of the Northern Hemisphere. The vaccine just wasn't working this year, and we were seeing a lot more H3. But it wasn't appearing in the community, which was really unusual. But like I say, nice guidelines state you have to prove it's circulating in the community for you to give out oseltamivir from the GP practices. So we pushed it in Wales. So this little bar at the bottom here is antiviral prescribing. And you can see here, you can actually see us prescribing oseltamivir in Wales. That doesn't happen very often. And actually, this is the highest year we've given oseltamivir out in the community since the last big year in 2010, 2011. But we really had to push it, because people were not, keen on it. There'd been that report basically saying that it didn't work. But actually, we had no deaths, really, a lot of deaths associated with it. So, it's better than, not treating them at all. So it was quite good. And treat early. If you suspect it, treat early, which was the other thing. Don't wait for the lab results. So if we talk at molecular testing for respiratory pathogens, flu, it was actually the swine flu pandemic that did us a huge favour, that it allowed us to really start looking at my hypothesis, what's normally circulating out there. So 2005, 2008, we tested about 2,000 new cases, and most of those came from haematology. So our most vulnerable patients were sending in respiratory swabs. We saw very little from anywhere else. 2012, 2015, we're now testing over 18,000 cases. So about 6,000 cases a year now coming into new cases. We do repeat testing all the time to see whether people are clearing viruses, but new diagnosis. And actually, these well-characterized surveillance samples are a useful source of information to help us understand these circulating patterns of emerging respiratory infections. So if something new arriving on the horizon, how is it circulating? How does that fit into the pattern? So we have a future model for respiratory diagnosis in Wales, and basically what we want the lab to do is test for a broader range of viruses and targets compared to what we would normally ask them to, because we normally tone down the screening. So we have a summer screening, we have a winter screen, but actually what we want to do is test for everything all year round in every patient group, and then we'll get a better understanding of what's actually going out there. So in the middle there you can see the range of targets, and you can go over to the Luminex panel because that's probably what we're going to be using to do this work. But around the outside you can see this ring, well, that's reference facilities, because when you're using commercial systems and you're only using a molecular system, viruses change all the time. Genetic changes. You can see that the flu changed this year, and sometimes that means that the molecular test will no longer detect it. And so what you need to make sure is that the reference facility surrounds that. Now, whether that's within your local lab or whether it's in a reference laboratory, that you send a proportion of those positive samples and a proportion of those negative samples where you really think that was an infection, just to find out whether there was something going on there with the virus that means it's changing and that assay is no longer detecting it. And so we have specialist services for our novel targets, so MERS-CoV, enterovirus D68, and also the emerging influenzas, because obviously it's not going to pick up your H5s and your H7s in this routine panel. So we're going to do molecular surveillance, Sanger sequencing, whole genome sequencing of those viruses we detect, just to make sure that everything is going to be detected as we go forward in this new model. And Flu A is sitting at the top. That is always going to have a special reference facility because of our role in the global surveillance networks. Problem is when you start looking for everything, you could actually cause yourself lots of problems. We recently had a death in Wales from a child with human metapneumovirus, and we had a Freedom of Information Act come through to Public Health Wales because apparently we didn't tell the GPs that human metapneumovirus existed. Now, it's not that we haven't told them, it's just that the information's out there, but, do we need to push it a little bit more, that these viruses are significant and can be severe? So actually, this was a real issue. Well, things that we know that influenza circulation drives testing. So over the years, so this is the last year that we had the Flu A and the Flu B circulating, very quiet year last year, and then this is this year. And I can tell you now that when I've gone back to look at the data, week 52 on week 1, which is the Christmas period, most of those cases were in accident and emergency because the GPs weren't open, out of hours wasn't open, and they weren't prepared to wait. So it was your accidents and emergencies in the big hospitals that were really taking the brunt of the flu epidemic last year. So GPs weren't seeing it at all, and that's why we have flatline levels, because it's all in the hospital. But what was really important was that the hospitals needed to know that flu was circulating, so we had to keep pushing that message. We have to keep saying, flu is there, but you may see it in a different place to where you would expect to see it. With flu comes an increase in excess mortality. And as you can see, going along here, so this is the last excess mortality, this is 2010-11, and we had a huge spike of it this year. Again, in the over 65s, it was an H3N2 year. That's exactly what you would expect to see. But is it all flu? Because interesting, when you look at the hospital surveillance, only 36.5% of the cases that we tested were actually influenza A positive. So a lot of people coming in with flu-like symptoms, but it wasn't really flu all the time. Interestingly, positivity rates always seem to remain the same, regardless of whether flu's circulating or not. So it seems to me that actually what you see is flu might knock other viruses out, or people may be more aware of flu, but other viruses fill in the gaps. This is last year. The purple bars are RSV, so you can see there's a lot of RSV here, but the green here, that's Rhinovirus. So Rhinovirus was actually taking up a niche where flu was no longer circulating. We're seeing a lot more Rhinovirus. And so you have these other respiratory viruses which are bringing people into hospital, but we're not really sure yet on their significance. RSV is an ongoing problem. We see RSV every year. Interestingly, seems to be going down in numbers, and I'm wondering whether or not we're having, because RSV has been so prominent in the last few years, whether we've actually got a pool of infants who are now immune, and what we'll see next year is another increase in RSV. You know, how does RSV actually fit into, you know, the epidemiology? And we're going to increase surveillance of RSV because there's now going to be vaccines available. And this is quite important as well, because if you give palivizumab to your neonates who are prone to RSV infections, we need to know how long the RSV season is. Do you need to give 1 dose, 2 doses, or 3 doses throughout the season? So RSV is actually something that we monitor quite well, but it's fairly predictable, as you can see. We know when it's going to start, we know approximately when it's going to stop. This is admissions to critical care in 2012, 2013. We didn't have much flu going. Beginning here, this is admissions due to flu B. RSV, flu B is in green, and then you get the later flu A, and you've got a little bit of H3 and a little bit of H1. So we had all 4 viruses really circulating that year. Importantly, it wasn't a great flu year. Rhinovirus admissions to intensive care, enormous number. And these are rhinovirus infections on their own, totally underestimated. You try telling a clinician they've got a rhinovirus, they won't believe you. They'll keep swabbing and swabbing and swabbing and taking lower and lower respiratory tract samples to find something else. Hard to believe that our rhinovirus actually causes infections. So we need to increase community testing to find out what's actually out there. So this is how we've done it. So I should just do this very quickly. So what we've done is we've developed a study. We're doing primary care, and we're going to do RE as well as ILI. So acute respiratory infections. So we want to reduce influenza disease specificity, because GPs are really quite good at noting when they've got flu, particularly if they've been in our sentinel surveillance scheme. We want to increase the detection of the other respiratory viruses. Are we going to start seeing RSV earlier in the community? Can we predict when it's actually coming into hospital? Is rhinovirus out there? Is it severe? What kind of people is it infecting? You know, are they in contact with vulnerable adults that we may need to know about? And also, influenza presents as a very mild disease as well, particularly if you have immunization, if you've already been immunized. So if you've already been immunized, you may have a mild infection. It may take you to the GP because you're a vulnerable group, take a swab, and it's actually flu. Normally, if you go with our ILI, you wouldn't take a swab. So we're trying to reduce that. See if we can pick up flu, that low level of circulation, bring that GP consultation rate up where it should be when we know flu's in the community. We also wanted to look at coroner's autopsies. And this is because we have all these sudden deaths that happen in the community all year round. And when they do the autopsy, they might say, looks a little bit inflamed in the trachea, looks a little bit inflamed in the lung, but they've taken no samples from virology in particular. Might do microbiology, but there's no virology, so we don't really know what's actually whether respiratory viruses are actually causing some of this death. So, yeah, we want to see whether we can get them recorded as well. So the RSV becomes as important as flu, and rhinovirus becomes as important as flu in this population. So if we look at some sentinel studies, surveillance studies, we had 110 samples submitted with this Iliari sort of mix, week 45 to week 23 in 2015. There were sort of like a few children, 12 of them were children under 16 years, so they potentially could have had the live influenza vaccine, and 8 adults were over 65 years, so should have been immunised. We had about 63% positive for one or more of the virus targets and pathogens that we were looking for, and 30%, so only about 43% were actually influenza A, but they were all H3 viruses. And so we're going to go back and sequence them to see whether they were this drifted strain. We also found about 10% dual infections. Dual infections fairly common in the community. And this is what it looked like in the weeks. So this is where we peaked in the hospitals, week 52. And as you can see, it kind of started slightly earlier in the community. So that's about right. You would expect to see flu first in the community and then in the hospitals. But we were detecting it quite early on. If you do surveillance all year round, you pick up these sort of sporadic flu cases, people coming back from southern hemisphere or countries where it is. But as you can see, the colours change and we get paraflu appearing later. And you can see we're looking for a huge range of viruses here in this population. If we compare that to the hospital surveillance, you can see this whole grey bar area where we get nothing. We just don't detect anything. And that's because we're not yet looking for absolutely everything in the hospital. We're still using our current in-house screen, which doesn't detect all of those viruses that we're looking for in other things. But generally, you can see that the peak in flu A is slightly later than what we see in the community. So it's doing about the right thing. The next thing we look at is the intensive care. Huge grey bars. Right, because I think that by the time people get to ICU, they've already cleared the virus. They're now on to their secondary complications. So they've got secondary bacterial infections, they've got their exacerbations of their underlying conditions, and that's what they're being managed for. But you can still see, in about week 52, just slightly later than the hospitals, you see that peak in H3N2 in the community, in the ITU. But again, we're not looking for everything that we're looking for in the community. So we're seeing a lot more of a wider range of viruses in the community than we were actually seeing in the hospital. But that's because we're not looking. And if you look at the ICU surveillance in age group, you can see that for RSV, you have this huge number of cases in the fives and belows, and particularly in the under ones, exactly where you would expect to see RSV. But you also see it in the older groups as well. So good proportion there in older adults pitching up in ICU. And this is flu. And so we had 85 cases, new admissions for flu over the things predominantly H3N2, but it also affected children as well. So we were seeing in a wide range of patients in the community, which wasn't reflected in the community surveillance. If we look at coroner's autopsy, so these are the people you wouldn't normally screen at all. 55 samples received from 40 cases. We were asking for upper and lower respiratory tract samples. Difference, 22 females, 18 males, so a good split there. 8 of those were children under the age of 16 and 24 were over 65. And we'll look at the over 65s in a minute because they're your excess mortality group. 80%, so a lot of viruses in this population. 8 of those, so only about 25% were flu A. So that was a bit of a surprise because, we had a big flu A season, but they didn't seem to be coming in coroner's autopsies. And 40%, so a higher rate of people with dual infections being detected from autopsy. So what you have here in blue bars is the community detections. So you have this nice flu A peak for the community, and you can see in the red bar, this is the coroner's autopsy. So you can just see a little bit of red there associated with those small proportion of cases that we were detecting with flu A. What was interesting, though, is if you come to this end of the bar, and this is adenovirus. There is an adenovirus that we were concerned about called adenovirus 14P1, and that's associated with severe infections and death, and it has been reported around the UK. So the first thing you do, because I noticed that this is unusual, part of my surveillance role, I sent them for hexon typing to find out what type of adenovirus these were. Were we seeing a problem in Wales? Because we were also seeing admissions to ITU at the time with adenovirus. And they weren't. They were just normal, routine, seasonal adenovirus cases. But obviously, we didn't realise how significant adenovirus was in sudden deaths. And also it's in the community, but also we're seeing it disproportionately in adults who've died from flu, from adenovirus. And these are the coronaviruses sitting here. So these are the normal seasonal coronaviruses. And in red, you've got the coronial autopsies. So not so much in the community, but we're definitely picking it up in those very severe end-of-life cases. So if we look at sudden death in the greater than 65s, you would expect it all to be flu. So 24 cases predominantly in South Wales. And that's predominantly where our flu season was. Very little flu activity in North Wales. The months of deaths, we had 2 in December, 9 in January, 8 in February, 5 in March. So it's across that good flu season there. Age range 65 to 95, mean age to 79. Fits exactly with flu deaths. 19 out of 24 were positive for one or more pathogens, but only 6 of those were flu positive. Only 6 were actually died from flu A. And one of those was a dual infection with C. pneumoniae, and one was dual with adenovirus. There's adenovirus again. 6 were adenovirus. So are we actually counting all excess deaths as influenza? And is that correct? Should we be looking wider? We had 1 dual with human metapneumovirus. RSV appears. RSV is a definite. We find that all the time in the elderly. They die from RSV as easily as children. Human coronaviruses, there's the rhinovirus there. So like I say, it's a very severe cause of disease. And 1 human metapneumovirus. Now what I'm just going to leave you with is some discussion here. So our sentinel surveillance scheme still primarily detects influenza, which is exactly what it's meant to do. We want it to detect influenza. The numbers are low. We don't get that many people going through, but I think it's because most of our population, it's a sick, socially deprived population. They go to accident emergency. They're not willing to wait. So should more surveillance be performed in hospitals? And this is something that us as the 5 Nations Flu, we're actually looking now at the hospital data more closely to see what information we can actually glean from that. And then what we find then is the coroner's autopsy result shows the circulation of a wider range of respiratory targets that might impact on tertiary services. And we should be looking at those because are we looking closely enough in our ICU cases to see, are these lesser viruses actually detected there? We're going to look at histology and we're going to look at implications for excess mortality. I presented this data to the 5 Nations Flu meeting and they were actually quite surprised at the lower level of flu that we actually found. So my final acknowledgements are to the people who do the data analysis for me, people who did some assay work for me when I was away, and Luminex who provided the next tag stuff for me to do the study.